My name is Tammy Brady, and I'm the Vice Chair for Clinical Research in the Department of Pediatrics, as well as the Medical Director for the Pediatric Hypertension Program. I'm really excited to share the results of our research entitled Association of Perinatal HIV Infection with Blood Pressure and Hypertension Among Youth. This research was presented at the Pediatric Academic Society meeting. As many of you know, human immunodeficiency virus, or HIV, is an infection that weakens the immune system and in advanced stages leads to acquired immunodeficiency syndrome, or AIDS. Between the late 1970s, when the HIV epidemic began, to the early 1990s, almost 15,000 children in the United States were born with perinatally acquired HIV infection. This means they became infected with the virus while they were either in the womb or during childbirth. Thankfully, since then, the number of children with perinatal HIV infection has decreased dramatically to less than 200 per year, but this has not yet been eliminated. Now, when people think about the complications of HIV, many think about infections or other problems stemming from having a weakened immune system. But HIV is also associated with an increased risk for cardiovascular disease and cardiovascular disease risk factors. In fact, adults and children living with HIV have more diabetes and higher cholesterol than those without HIV. And adults with HIV have more hypertension and heart disease. What we don't yet know, though, is how HIV infection affects blood pressure in children. We aim to answer this question by analyzing data obtained in the Pediatric HIV/AIDS Cohort Study, or the FACT study. The FACT study is a prospective study conducted at 15 sites in the United States with the goal of investigating the impact of HIV infection and antiretroviral treatment on youth. So children who were perinatally infected with HIV and children who were exposed to HIV in utero but ultimately uninfected were enrolled between 7 to 16 years of age and followed each year. These annual assessments included blood pressure measurements, imaging, and laboratory evaluations. In our study, there were 673 participants who had blood pressure measurements. 447 of those were youth living with HIV, and 226 of those were exposed but uninfected. In our study, youth living with HIV were more often Black race and non-Hispanic, and they had lower measures of adiposity, meaning they had lower mean weight and lower mean body mass index. They were also shorter in height. Systolic blood pressure and hypertension were similar between the groups, but diastolic blood pressure was lower for pre-adolescents living with HIV than the youth who were exposed but uninfected. Before starting our study, we thought that the degree of adiposity and age might modify or impact how HIV associates with blood pressure. However, our analyses did not support this, so those two variables were included as confounders in our analyses. And what we ultimately found was that in the least fully adjusted models, it seemed as though HIV infection was associated with lower diastolic blood pressure and lower odds of having a hypertensive blood pressure. However, when we accounted for degree of adiposity by including body mass index, there was no longer an association between HIV infection and blood pressure in youth. These results suggest that adiposity may explain the observed association between HIV infection and blood pressure among youth, and really emphasize the importance of lifestyle counseling for cardiovascular disease prevention, even among our most vulnerable youth. I'd like to thank the study participants, the clinical sites, the FACTS community advisory boards for making this study possible. Thank you very much.